The infant brain displays signal characteristics that are the inverse of an adult brain. This appearance is driven by the physical composition of immature myelin. Because infant myelin holds a high volume of water and very little fat, it registers as dark on T1 sequences and bright on T2 sequences. Traditionally, medical training treats the resulting variations in pediatric neuroimaging as a list of isolated syndromes. This approach relies on a catalog of complex Latin and French classifications, a method that frequently fails under the pressure of clinical evaluation. An embryological timeline provides a structured path through these pathologies, categorizing brain development into 4 distinct failure modes: failure to form, cleave, migrate, and organize. By reverse engineering the developmental stage where the process halted, diagnosis becomes a matter of mechanistic deduction rather than passive pattern recognition. This diagram shows myelin maturation. Water decreases, fat increases, inverting the signal. Mature white matter is T1 bright, T2 dark. T1 changes appear by age 1, T2 by age 2. The spatial progression strictly moves inferior to superior, posterior to anterior, and central to peripheral. Establishing this normal spatiotemporal vector is a strict prerequisite. Identifying structural delays requires knowing the precise expected location of myelin for a patient's age. The first node is failure to form, like agenesis of the corpus callosum. It forms front to back. If halted prematurely, the anterior genu remains intact, but the posterior splenium is absent. This forces lateral ventricles widely apart, while occipital horns dilate asymmetrically, called colpocephaly. The widely spaced parallel ventricles are caused by Probst bundles, white matter tracts destined to cross. Because the crossing structure never formed, the tracts run parallel to the interhemispheric fissure, forcing them outward. This mid-sagittal illustration shows how formation failures present in the posterior fossa. A classic Dandy-Walker malformation requires 3 exact features: a hypoplastic, elevated vermis, a massively dilated cystic fourth ventricle, and an elevated tentorium. The upward displacement of that tentorium produces torcular lambdoid inversion, where the venous confluence sits above the lambdoid suture. If the vermis is hypoplastic and rotated, but this torcular inversion is absent, the diagnosis is downgraded to a Dandy-Walker variant. Confirming a failure to form requires checking 2 separate anatomical boxes, identifying the missing primary structure and correlating it with the specific spatial displacement of surrounding tissues. The second node identifies failures of midline cleavage, which includes the holoprosencephaly spectrum. Normal central cleavage occurs posterior to anterior. Holoprosencephaly is the failure of the hemispheres to separate during this exact back-to-front process. In the most severe expression, allobar holoprosencephaly, there is 0 midline cleavage. The patient presents with a single midline ventricle, fused hemispheres, and an entirely absent anterior falx. In milder lobar holoprosencephaly, the posterior brain achieves partial cleavage, allowing posterior horns to separate. However, the frontal horns of the lateral ventricles remain fused at the front. By tracking the normal back-to-front cleavage vector, we understand why the frontal lobes are always the most severely impacted region across the entire holoprosencephaly spectrum. The third and fourth nodes dictate cortical architecture. Cortical neurons are born deep inside the brain, originating in the dense periventricular zone. From this deep origin point, cells migrate outward in 6 successive waves. The process functions on an inside-out model, where younger neurons must climb past older cells to reach their final superficial position on the cortical plate. Stunted migration is highly visible. Classic Lissencephaly leaves neurons short of the surface, creating a smooth, thick cortex with a figure 8 appearance. If neurons never detach, periventricular nodular heterotopia occurs. Gray matter forms distinct nodules directly along the lateral ventricle's borders. To differentiate this from other pathologies, check the MRI signal. Heterotopia strictly follow gray matter intensity, distinguishing them from the brightly calcified subependymal tubers found in tuberous sclerosis. Even if migration succeeds, organization can still fail. In polymicrogyria, deep cortical layers are obliterated. Without that deep foundation, the superficial layers overfold and fuse, creating an excessive number of fine, undulating bumps on the brain surface. The macroscopic folds visible on an MRI serve as a direct, readable record. The physical shape indicates precisely where microscopic neuronal migration halted. The final diagnostic challenge is distinguishing these true embryological failures from severe destructive events that occur after the brain has formed. Compare open-lip Lissencephaly with a porencephalic cyst. Both present as large defects connecting the ventricle to the surface. Porencephaly is an acquired injury, so its border is lined by white matter. Lissencephaly is a developmental failure, meaning its cleft retains a continuous gray matter lining. This provides a definitive diagnostic rule. True embryological clefts are consistently lined with gray matter. Acquired destructive mimics lack that gray matter layer. Identifying this single tissue biomarker immediately reclassifies the etiology. You can distinguish a congenital malformation from an acquired in utero insult based entirely on the cellular lining. Evaluating severe structural loss requires a concise triage algorithm. First, check if the cortical mantle is present. Second, look for the anterior falx. Third, inspect for gray matter. Running these findings through the framework logically isolates the structural errors. Discarding syndromic memorization in favor of a mechanistic timeline removes the guesswork. It equips residents to systematically deduce the biological origin of any pediatric central nervous system pathology.